Hello, and welcome to the December episode of the Axial Spondyloarthritis podcast series. Alongside this podcast, we'll also be bringing to you RA and PSA podcasts and monthly slide decks that help you to keep up to date with the latest research and publications in the field of axial SPA. My name is Sofia Ramiro. I'm a rheumatologist and senior researcher at Leiden University Medical Center and Zuiderland Medical Center in the Netherlands. And today I'm joined by Hideto Kameda, Professor of Internal Medicine at Toho University, Xenfon Baraliakos, Professor of Internal Medicine and Rheumatology at the Ruhr University in Bochum, and Medical Director of the Rheumatology Center, Rheumatzentrum Ruhrgebiet in Herne, Germany, and Atul Deodhar, Professor of Medicine and Medical Director of Rheumatology Clinics in the Division of Arthritis and Rheumatic Diseases at Oregon Health and Science University in Portland. We hope you enjoyed this episode of the AxSpA podcast. If you would like more information on the paper we will be discussing today, please head over to the Immune-Mediated Inflammatory Disease Forum website at www.imidforum.com, where you can find full slide summaries of this paper. So Hideto, over to you, please.
Thank you, Sophia. We will be discussing one paper today in which the authors investigated the efficacy and safety of Upadacitinib in patients with active ankylosing spondylitis refractory to biologic therapy from the Select AxSpA study. Now, Atul, would you explain the background and methods of this paper?
Yeah, thank you, Hideto. This paper is a recent publication from me and Xenfon and our colleagues titled Efficacy and Safety of Upadacitinib in patients with active ankylosing spondylitis refractory to biologic therapy. 2-year clinical and radiographic results from the open-label extension of the Select AxSpA study. So the background is that the study evaluates the efficacy and safety of Upadacitinib in patients who have ankylosing spondylitis and also have an inadequate response or intolerance to biologic DMARDs before participation in the trial over a 2-year period in the Select AxSpA study. This study included patients aged 18 years or older with a confirmed diagnosis of ankylosing spondylitis meeting the modified New York criteria and exhibiting active disease at baseline defined by specific scores on the BASDAI and pain assessment. Generally, these are BASDAI more than 4, back pain more than 4. Participants received either continuous Upadacitinib or switched from placebo to Upadacitinib at week 14. Efficacy endpoints were measured using the ASAS and ASDAS responses, along with changes in disease activity, back pain, function, and quality of life. More importantly, the radiographic progression at 2 years was evaluated using the modified Stoke ankylosing spondylitis spine score. Xenfon, you can tell us the results.
Thank you very much, Atul. And yes, I'm happy to provide that information. I'll be sharing with you the results and the conclusion for the study. Overall, we have included 420 patients. They entered the biologic DMARD inadequate response study for radiographic axial spondyloarthritis or ankylosing spondylitis. 409 altogether participated in the open label extension, and 331 completed the 2-year assessment. So we have a pretty large number to compare and analyze. At 2 years, at week 104, about 65% of the patients in the continuous group with Upadacitinib and about 62% of those who switched from placebo achieved ASAS-40 response, indicating indeed a significant improvement in disease management. Similarly, improvements from week 14 through week 104 were observed improvements were observed in measures of function, of mobility. This means BASFI, BASMI. For enthesitis, this is MASES, quality of life, such as AS-QOL and ASAS Health Index, and inflammation measured by the high sensitivity CRP in both groups. The study reported no radiographic progression through 2 years of treatment. This means up to week 104. With about 95% of patients in the continuous group of Upadacitinib and about 94% of patients who switched from placebo to UPA, showing a change from baseline in an MSAS of lesser than 2 units, which indeed is really either minor or background noise at, again, week 104, highlighting the treatment's effectiveness in preventing long-term structural damage. So overall, what we can conclude is that the findings from the SELECT AxSpA study suggest that upadacitinib is a promising treatment option for patients with ankylosing spondylitis who have inadequate responses to previous therapies, which is very important for our daily practice. Those sustained improvements in efficacy measures and the high percentage of patients without radiographic progression do underscore the potential of upadacitinib in the management of ankylosing spondylitis and its effective overall effect. And the treatment, I would like to repeat, was well tolerated with no newly identified safety signals. This is the overall study report, and I'm pretty happy to take up the question, Sofia.
Thank you very much, Xenfon, for this nice presentation. And indeed, we have a nice overview of the efficacy. You also now added a concluding statement on the safety findings that we also have from this study. And I think it's good to emphasize before we start discussing the content that it's very good to have this type of studies in this type of patient population that demonstrates insufficient response to biological DMARDs. Actually, it's the second of these studies that we have in the field completely dedicated to a population that has shown a trial specifically dedicated to a population that has shown insufficient response, which I think is very useful for our daily clinical practice, where we often start treatments in patients that have already failed before a previous DMARD. So I think it's very good to have this data. I would like us to discuss a little bit on how we put these findings into perspective, because on the one hand, of course, we do not have a comparator here. And on the other hand, we also know how challenging it is to compare results across trials, and especially when we are saying we only have two of these trials where patients have been included with insufficient response to biologics. But let's do the best and help our audience also interpreting this data. How would you interpret them in the landscape of the treatment armamentarium that we have for AxSpA? Maybe Atul, you want to start?
Yeah, so this population is the population where in the US, we can use JAK inhibitors. We cannot use, as opposed to Europe, we can only use it in patients who have tried anti-TNF drugs first. So this is very, very pertinent for US. That's point number one. Point number two, these are generally patients who are more difficult to respond to therapy. These are more resistant patients. These are the sort of difficult to treat because they have tried anti-TNF one and they have failed it for some reason or the other, inadequate response or side effects. And then with limited armamentarium we either go to IL-17 inhibitors or JAK inhibition. And so this is a very important paper from that point of view. And the second point I wanted to raise was we have a fairly good idea that long-term treatment with anti-TNF or even IL-17 reduces radiographic progression. And this is the first study where JAK inhibition has been shown now looking at X-rays in these patients with this modified stroke ankylosing spondylitis score. That JAK inhibition also has the capacity of at least, I mean, again, there is no placebo going all the way up to 2 years, but the rate of progression seems to be very minimal. And that also is reassuring, I think, for the listeners that so all three classes of agents that we have, TNF inhibitors, IL-17 inhibitors, and JAK inhibition, they all appear to reduce the rate of progression, slow it down. We will never have a study with 2 years of placebo, but we can make our judgment looking at how much progression there has happened in the last 2 years. So overall, I think a very important study indeed.
Yeah, thank you very much, Atul. I am happy we have emphasized that last point as also a very important point indeed. The limited radiographic progression we have seen, which is something we had not yet seen in a trial with JAK inhibition, and emphasizing that this has been shown in this specific more difficult to treat population of patients that have already failed at least one biological DMARD before. So I think that is convincing in terms of the effect on potential effect on radiographic progression because of the lack of comparator, as you were saying. Maybe now we can hear your input, Xenfon, on the first question on how we interpret this study in the landscape of other options that we have.
So I believe you've already covered those topics that are important, and that's why that publication was also put in place. This means we do need alternatives, not because we're not happy with the other treatments we've had so far, but because we may not capture all patients' wishes as well as treatment with treatment effectiveness or efficacy, really get everybody in a good shape. That means we want alternatives in terms of convenience of the drugs. We have here the data that are showing how good oral medication with JAK inhibitors may be in patients with ankylosing spondylitis / radiographic spondyloarthritis. We have long-term data now. The efficacy is included, showing no effect, and also the reassurance of the radiographic progression. So that overall is already important, and especially we have now the data in those patients where we may fail the, let's say, so far conventional treatment with biologics, which is the previous treatment with TNF blockers or IL-17 inhibitors. So I summarize what you just said, both of you, because I think that's exactly the essence of this publication.
Thank you very much. Maybe we can address one last point, which we have already partially also commented on, but that is safety, because Atul already started by saying in the US, JAK inhibitors are not allowed to be prescribed in first line, only patients that have failed TNF inhibitors. What do we have any comments on safety findings? You summarized it very briefly, Xenfon, but in the light of the warnings from FDA and from EMA, do we have any? Can we conclude anything in terms of safety and the risk of especially major adverse cardiovascular events with the Upadacitinib in the population of AxSpA?
Absolutely. I would like to emphasize that indeed it might be different in other parts of the world, such as in the European area where the EMA has a more, let's say, or not so conservative view, let's put it like this. I would also like to mention that there might be also advancements and developments in that field. Very recently, the German Society of Rheumatology posted a statement that the safety issues, especially in diseases such as axial spondyloarthritis, where the population is much younger, that they do not really see the necessity of putting out a warning, but they do say that we do need to wait and weigh the risks, especially in people who have been smoking for a very long time, plus those who have had the atrial thrombosis in the very recent history. But then again, it is not a warning, but it's like a precaution statement. So altogether, we see things that are getting softened. I understand FDA's position, but on the other hand, we also understood that we need to see all these patients or see the patients separately based on indication, on disease. Axial spondyloarthritis is not considered such as comorbid conditions as, for example, it is in rheumatoid arthritis in advanced stages. So, and of course, the needs of the patient need to be taken into account. So overall, my statement is we're getting there to really get a better freedom of choice, which I would very much appreciate. And then it's up to us to weigh the risks.
Yes, indeed. It's a lot about stratification of risks, and the more we learn about it and the more we see that in the data. Any comments from any of you? I think, Atul, you are wanting to say something.
Yeah. So in this study, there was, so point number one, this study was conducted during COVID pandemic. So there were cases of COVID pneumonia, and there were cases of COVID, and patients were admitted also. Some of them were considered to be serious by the investigator. And all biologics, this is not a biologic, this is a synthetic, targeted synthetic molecule. But this does suppress your immune system enough that patients can get significant infections. So that point was, again, very obvious during this study being conducted there. I mean, the events, which is another interesting thing, that the company which did this study, they don't talk about rates, they talk about events. And so it's difficult to compare across studies about the safety. So there were about 1.5 events per 100 patient years of COVID pneumonia, and another 0.6 of just COVID infection events per 100 patient years. There was one patient who had pulmonary embolism in this, which was life-threatening. There was one death in the study, but that was because of polytrauma. We don't know what exactly the trauma was. And interesting, what caught my eye was uveitis. So there were 9 events of uveitis, and 5 were again thought to be serious, which is very bizarre. So they probably had to stop the treatment. That's why it was thought to be uveitis. And out of those 9, 3 were recurrent uveitis. So I just want to bring a point about JAK inhibition and uveitis. And there was a paper that I read in the summer this year about filgotinib and uveitis, and this was in JAMA Ophthalmology, different journal. And filgotinib seems to be useful in uveitis. There is a study I'm aware going on about phase 3 study, mostly in Europe, I suspect. Brepocitinib or something like that, I want to say. This is a JAK inhibitor on uveitis. So this is the curious thing, that whether JAK inhibition reduces uveitis or not would be something that we really don't know. These drugs do work on inflammatory bowel disease, but there was one new onset inflammatory bowel disease of moderate severity occurred in the study. So these are, I understand, these are small events. 2-year studies on small number of patients are not really adequate to decide about seriousness or side effects. And I agree with the first statement that Xenfon made, that nothing new has come out. One pulmonary embolism, I mean, yeah, we understand that we have to be careful. These are young patients, but still always have to keep that in mind. So just a word of caution.
Thank you very much, Atul. Any final comments, Hideto, that you would like to make? Otherwise, we will. Yes?
Okay. One thing I want to add is that it should be noted that we can see the cumulative probability plots of the changes in both MRI score and radiographic score over 2 years in supplementary figures of this study. So I strongly recommend to refer to supplementary figures of this paper. Thank you.
Very good. Thank you very much, Hideto, for this final, very useful note. I think this is bringing us to the end of this podcast. Thank you very much for joining us for this AxSpA podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. We really hope you find it useful. And if you did, please don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. And if you want to read more about what we have discussed today, head over to www.imidforum.com, where you will find the summary slides of this paper. See you next time.